So Dr. French is our next speaker. She's assistant professor of neurology and vascular neurology. Now before coming to us via Kansas City, she was also the associate stroke program director at Swedish Medical Center in Seattle. And I mentioned that because that was one of the first established stroke programs in this country. She's board certified in neurology and vascular neurology and is of course a key faculty member in stroke program in the Department of Neurology. And she is going to talk to us about aspirin and stroke prevention. Now, from Dr. Flaker, we heard aspirin is good, maybe good in men for one reason, women for another reason, heart disease in one, and stroke in the other. But we'll now hear the focus on stroke. Dr. French.
Good morning. I'm Dr. French. And I will apologize one time at the beginning of my talk. I've been desperately trying for weeks to get rid of this cold. And so if I start coughing uncontrollably, give me a minute. So today I'll talk about aspirin and stroke prevention. And I have nothing to disclose. There is a lot of data regarding aspirin and stroke patients. There's not a ton of it in primary prevention, however. We have several large trials that had stroke as a combined endpoint that were conducted many, many years ago. And we found that aspirin has some role, but it's not necessarily a tremendous role. Patients who have a high risk, where the benefits, the absolute benefits of stroke prevention outweigh the bleeding risk, are patients who would be appropriate to use for aspirin, and there are a variety of risk stratification tools that you can use. We do know, for instance, that women who are of high risk, I would consider the use of 81 milligrams of daily aspirin for stroke prevention. As Dr. Flaker mentioned before, it seems that the compelling evidence for women is more as it pertains to stroke rather than coronary artery disease. And equivalently, for men, it must be a significant increase in stroke risk or cardiovascular risk before we actually prevent any events. Aspirin is not useful in low-risk patients because the hemorrhagic risks do outweigh the benefits in stroke prevention. And there used to be this assumption that in patients with diabetes, because they do have a significant increase in all vascular disease, that it would be useful in stroke prevention as well. And we found that that's also not the case. So just one representative piece of information, when you randomize low-dose aspirin versus placebo in women for the prevention of cardiovascular disease, what we found is that for major cardiovascular events on the first line, there's not that striking of a risk reduction. However, we did find that the only statistically significant benefit was for the prevention of ischemic stroke, and that's down on the third line here. We found that MI didn't change, death didn't change overall, TIA, down a little bit lower, didn't have any significant changes either. But we did find the increase in prevention of ischemic stroke. And therefore, women who are, again, of the age of 55 or older, aspirin is recommended for the prevention only of stroke. When you look at patients overall, this is a meta-analysis of, it looks like 129 studies to determine whether or not aspirin is useful. We found in male physicians who we'll assume are a relatively healthy cohort, there's not any particular benefit to aspirin. In fact, on that first line, we found that those patients uniformly did worse, mostly because of bleeding complications. Even in patients with vascular risk factors, though it was a smaller number of trials, we found that it's fairly equivalent. So this is when you combine the hypertension and the hyperlipidemia and the diabetes. But in patients who have documented vascular disease, what have you, not stroke, the antiplatelet treated patients did better. And therefore, again, in patients who have a higher risk of stroke, we do recommend the use of low-dose aspirin for the prevention of stroke. And so how do you assess that risk? And there are a significant number of risk factor tools that you can use. The one that is cited most often when you discuss the guidelines in the American Heart Association and Stroke Association literature is going to be the Framingham Stroke Profile. It gives us a nice number as far as 10-year risk of assessing stroke. And so it's nice, it's a table, it's fairly simple to follow, and it assesses multiple risk factors, and you get a point stratification. And at the bottom of the table, it will say, based on the number of points, this is the associated 10-year risk. And so it uses features such as both the treated and the untreated systolic blood pressure, diabetes, smoking status, other vascular disease, atrial fibrillation, which is sort of its own special case as far as stroke prevention is concerned, and then documented left ventricular hypertrophy on echocardiography or on EKG. And you can get a nice number, and this is the number, and this would be the information we would use under that first point as far as assessing that high 10-year risk and those patients who might be appropriate candidates for primary prevention with aspirin. Aspirin in primary prevention is probably most useful in those patients who are not candidates for anticoagulation, who have atrial fibrillation. There's obviously a significant increase in stroke risk overall in patients who have AFib. At least 10% of all strokes are felt to be related to atrial fibrillation, and that percentage increases as the population ages. We know at least 3.5% of patients with atrial fibrillation have an absolute, that's the absolute stroke rate of 3.5% in patients over the age of 70 with AFib. And so we also believe that a large number of patients with atrial fibrillation aren't diagnosed. A large number of them are diagnosed and not necessarily treated either. But there's this significant number of stroke patients who come in who have a new diagnosis of atrial fibrillation, and we think, well, how could we have found this prior to? Knowing also the risk with atrial fibrillation is equally prevalent in those who have permanent AFib versus those who have paroxysmal atrial fibrillation. We found in a study in Britain that you can screen this in the office, in the primary care office or any other office, by pulse assessment and by EKG in routine visits for patients who are over the age of 65. And so what we found is that the control group in this study were just patients who would complain of palpitations, shortness of breath on exertion, and so on. And they would find a small number of increase of atrial fibrillation patients. The intervention group were patients who either had screening EKGs, the systematic intervention group, or patients who just had pulse assessment by someone who was specifically looking for the irregularity rather than just a quick pulse check in order to document this. But that pulse was held over, I believe it was 1 minute of time to determine any rates of irregularity. And what you found was a pretty significant increase in the number of new diagnoses of atrial fibrillation. These patients then would potentially be candidates for, based on their risk factors, for some form of stroke preventive therapy. So it's very easy to perform in the office and felt to be potentially highly effective in documenting or determining these new diagnoses. So what do you do with a patient who has atrial fibrillation? And the American Heart Association, American Stroke Association doesn't have any particular scoring strategy that they recommend, but the CHADS-2 and the 2006 guidelines for the American Heart Association do at least give you something to go on. I use CHADS because I can remember it. It's a point system with congestive heart failure, hypertension, and so on. And it scores from 0 to 6. And basically, we're interested in patients, about 1 is the cutoff. So 0 to 1 are felt to be low and moderate risk. High risk is going to be greater than 2. The patients who are at high risk benefit from warfarin anticoagulation. The patients who are at low risk, however, are not necessarily going to benefit any more from warfarin anticoagulation than they will from the use of aspirin, particularly when the bleeding risk is taken into account. So in a patient with a score of 0 or 1, of 0, the recommendation is for low-dose aspirin therapy for stroke prevention. In a patient who has moderate risk, it's more of a discussion with that patient as far as the risks and the benefits of anticoagulation. and maybe looking at some of their other risk factors, lifestyle, et cetera. And it's a determination with that patient as to whether or not they'll choose aspirin or warfarin. Sometimes even access to good monitoring or the ability of a patient to remain compliant with a medication such as Coumadin or warfarin would be a salient feature of that conversation to have. Beyond that, unless there's a contraindication, again, it's warfarin. So again, recommended in low risk and some moderate risk. High-risk patients who are unsuitable for anticoagulation could also be considered as aspirin therapy. If the unsuitability has more to do with difficulties in compliance and monitoring INR, and these guidelines were published before some of the widespread use of the newer anticoagulant agents. But if it was a difficulty with controlling anticoagulation, an allergy, skin necrosis, some other form of difficulty with anticoagulation, then you could consider using dual antiplatelet therapy. There is, however, an increased risk of major bleeding. In patients who have a hemorrhagic contraindication to anticoagulation, the recommendation is still for low-dose aspirin without combining it with additional antiplatelet agents. And we'll find the same is true, and I'll go through that in a bit more detail when we talk about secondary prevention of stroke as well. Hypercoagulable states are really an area of controversy when it comes to stroke. Just about every hypercoagulable state is generally going to be associated with a venous thrombosis rather than an arterial thrombosis. If you're a child or a young adult, there is potentially an increased risk of stroke with these hypercoagulable states, and the mechanism is not necessarily known. But most of the time, these are going to be venous thromboses, and they may not even be relevant as far as it comes to stroke. We do know specifically with antiphospholipid antibodies, because they've been studied a bit more as far as stroke is concerned, that they are more associated potentially with stroke, but there's really no role for aspirin in the prevention of a patient who has not had a stroke. So again, primary prevention, regardless of the increased association, there's no data to suggest that we're actually helping these patients who have some hypercoagulability. Now again, when patients have venous thromboses, that's a completely different story, and we treat the venous thrombosis, and we don't worry about the role of aspirin as it particularly pertains to stroke. But we do know that there are a number of patients out there who are heterozygous factor V Leiden, for instance. There's no particular or compelling information out there to suggest that placing these patients on aspirin for prevention really of anything is actually driven by guidelines. So the bulk of the information about stroke prevention with aspirin is going to be in secondary prevention. Large artery atherosclerosis, and by this we're talking about extracranial disease of the carotid and the vertebrobasilar system, and intracranial atherosclerosis accounts for about 30 to 35% of all ischemic strokes per year. And so what's the role for aspirin in secondary prevention of these conditions? In carotid stenosis, there's a lot of literature out there as far as revascularization and carotid endarterectomy. Not necessarily as much for pure aspirin therapy, but we find that patients who have a significant degree of carotid stenosis require revascularization anyway, and those patients are all on antiplatelet therapy, and typically those patients are on aspirin. We also find that in patients who have lower degrees of carotid stenosis who do not require revascularization therapy, that aspirin is generally recommended by a consensus panel as part of optimizing the risk factors for recurrent stroke, along with optimizing the cholesterol profile, the LDL primarily, optimizing control of diabetes, and hypertension. And hypertension is probably one of the more salient additional features in addition to aspirin therapy. So that's kind of where we are as far as carotid stenosis. We don't recommend anticoagulation for these patients. Vertebrobasilar stenosis, apparently in times past, there was this sense that, first of all, the vertebrobasilar system was inaccessible, but potentially there was less risk of recurrent ischemia in patients who had actually had vertebrobasilar ischemia rather than anterior circulation or carotid TIA or stroke. We found actually that this particular analysis challenged that notion and found that in vertebrobasilar disease, there's actually a higher risk of stroke recurrence in the first 7 days than if someone has a carotid-associated stroke. Now, we think that once you can stabilize the patient through those first 7 days, the subacute risk for stroke is less than with carotid disease. And so this is the information, and in the handout, this is a fairly busy slide. And it's a busy slide on my screen, too. But what we found is that in this first group of patients, those were patients who throughout multiple studies were evaluated for recurrent ischemia at various time points. So this is in the acute and more the subacute and the chronic phase of vertebrobasilar ischemia. And we did find that those patients, when you compare it to carotid artery strokes, this is the group that actually had more strokes. They were in the acute phase, and it was a statistically significant increase in the stroke risk with vertebrobasilar disease in those first 7 days. Not so much once you got them out acutely and chronically, where the risk falls out on the other side of the line. And so we'll talk a little bit about atherosclerosis. Those patients are all candidates for aspirin. So what do you do with intracranial atherosclerosis? It was felt by many for some period of time that perhaps those patients should be anticoagulated, particularly if they have a significant degree of stenosis. And that's not found to be the case at all. In this trial that was completed in 2005, comparing warfarin and aspirin for those patients who had symptomatic intracranial atherosclerotic disease, we found that yes, there is a high risk of recurrence with severe stenosis. And by severe stenosis, we're talking about angiographically greater than approximately 70%. Within the first 17 days, these patients did have a statistically higher risk of stroke. There was also a higher risk of recurrent stroke in women. The study, unfortunately, well, perhaps not unfortunately, but it was stopped early due to systemic hemorrhagic concerns in patients in the warfarin arm, but also found there was really no reduction in the stroke risk in placing these patients on anticoagulation, either in the acute phase or in the chronic phase of atherosclerosis. And so what we have is this table showing these patients were followed for about 4 years before the study was stopped. But what this table is basically showing is that the red line of warfarin and the blue line of aspirin are essentially that same line. The stroke risk was about 23% higher risk of stroke in patients who had greater than 70% stenosis. But we found that TIA and less than 70% really didn't have that terribly increased risk of stroke. I suppose 15% could be. But again, anticoagulation did not show any benefit for these patients. And this is just a graphical because I'm graphic and pretty visual when it comes to looking at some of these data. But then if you look at the breakdown, these patients had a primary endpoint, I should say, of stroke or other vascular-related death. If you look at the breakdown, however, you do find that the increase in major hemorrhage down here was about the only statistically significant change between the groups. It was not in stroke prevention, it was not in MI prevention, but there was a significant increase in bleeding complications. And so otherwise, as far as event recurrence, those patients were fairly equivalent who had symptomatic intracranial disease. Again, probability of death increased in the warfarin group in panel A. In panel B, the probability of a major hemorrhage was also increased, but no improvement in stroke. Now, atrial fibrillation is a little different. It's indicated, aspirin is indicated as monotherapy, and this is 81 milligrams. When there's the hemorrhagic contraindication to warfarin, so just as in with primary prevention. For secondary prevention, we do not routinely recommend the combining of aspirin with clopidogrel. And we really don't recommend combining it with warfarin because the hemorrhagic risk becomes fairly great. Sometimes you're stuck when these patients have other disease outside of the central nervous system. These patients who have very symptomatic coronary artery disease, this is when we have to get sort of tricky when it talks about the combining of these antiplatelet agents. And so as we go through this information, I'm primarily talking about stroke prevention, and I'm taking that in exclusion of other disease in other vascular beds. When they have disease in other vascular beds, we have to get very conversational with our colleagues across the street as to what are we going to do modifying the remainder of their vascular risk factors. So what we found many years ago, before I was doing this, is that we found that aspirin is helpful in patients with atrial fibrillation, but warfarin is better. And so the panel on the left is looking at whether or not warfarin is effective for risk reduction in patients who have had TIA when compared to placebo. And the panel on the right is more of a comparison of aspirin. And so as we probably all know in this room, yes, warfarin is the treatment of choice in atrial fibrillation, but we do find that aspirin is of some marginal and statistically significant benefit in patients who are unable to take warfarin. When you add clopidogrel to aspirin in patients who have atrial fibrillation, again, the lines are fairly close when it talk about primary outcome in the first panel. There's really not a lot of difference in stroke or heart disease or coronary artery disease prevention. In stroke, we may have found actually that clopidogrel plus aspirin does have some degree of lower risk as far as prevention of further stroke. Unfortunately, we found that the primary and larger degree of statistical significance was the difference in the hemorrhagic rate. So everywhere across the board, other than in fatal major hemorrhage, the bleeding risk being so much higher actually offset any perceived benefit of the combination of aspirin and clopidogrel in patients with atrial fibrillation for secondary prevention, just as we found in primary prevention. The risk of intracranial hemorrhage is higher, the risk of gastrointestinal hemorrhage is higher, the risk of, or the increase, there's an increased number of transfusions in patients who are treated with combination therapy. Either without increased risk in the combination endpoint or with only marginal benefit as far as it pertains to stroke. So again, in patients who are not able to take warfarin because of a hemorrhagic contraindication, we don't recommend the combination of aspirin and clopidogrel. Patients who don't have hemorrhagic problems, we do know that the combination therapy can provide an increased benefit in stroke risk, and so we have to sort of take all of that information as far as hemorrhage into account when we're determining best therapy for these patients. Now, there are some other cardioembolic conditions, and cardiomyopathy with a significantly decreased ejection fraction is one. And the guidelines recommend either antiplatelet or anticoagulant. So what we found in this study from actually last year is when you compare warfarin and aspirin in heart failure for patients who are in sinus rhythm, there is a decrease in stroke with warfarin. And unfortunately, it's found, as in so many other studies before, it's offset by a significant increase in the hemorrhagic risk. And the data are very similar graphically to what we've already been shown. There are other cardioembolic conditions for which aspirin is considered to be probably more relevant than anticoagulation. These would be things like mitral angular calcifications, mitral valve prolapse, non-rheumatic mitral valve disease. It can be considered as additive therapy for patients who have mechanical valves and who have stroke or TIA despite adequate anticoagulation. That is probably the only guideline-driven recommendation for combination of warfarin and aspirin in stroke prevention is for the patients with mechanical valves. It's also recommended that the target anticoagulation be at the lower end of the range, more in the 2.5 to 3 rather than the 3 to 3.5 range for those particular patients because the bleeding risk becomes so high. So when we talk about non-cardioembolic stroke, antiplatelet therapy is the only recommended therapy, just like it was with extracranial large artery atherosclerosis or intracranial disease. There's been found to be no role for anticoagulation in any other form of stroke. Again, we do not recommend the combination of aspirin and clopidogrel. We found that when you're trying to choose the dose of aspirin, well, what are we supposed to do? And this is a meta-analysis from back in 1999. And what we found is that the line in the middle of the graph is essentially unity. Anything below that line has a lower risk with aspirin. Anything above that line, patients were at higher risk for either stroke or hemorrhagic complications on aspirin. And you found it's actually low-dose aspirin where the benefits are. So the first number is 50, followed by 300, or our standard 325. In addition to that, you actually see that black line raising or rising slowly to meet up at the higher doses of aspirin. The 3 and 4 aspirin tablets a day provide essentially not any significant benefit in stroke. They do give a significant number of hemorrhagic complications, however. And so based on this information, this is where we start to get back to the 81 milligram, the baby aspirin, is equally effective and potentially more beneficial for patients because of the side effect profile as that dose of aspirin raises. There is no information out there that really suggests that increasing the dose of aspirin for secondary prevention of stroke in patients who already came in on aspirin provides us with any improvement in stroke risk. Often comes the question, well, what do we do now with these other antiplatelet agents? What do we do with the patients on clopidogrel or the combination aspirin extended release dipyridamole? Its trade name is Agrinox. How do we choose between all of these agents? And there are a significant number of trials, and they compare one to the other and one to some of the others and some to placebo. And I could take you through all of that information, but I've given you the references here because essentially it doesn't matter. There are trials that will recommend that clopidogrel is potentially more favorable than aspirin. Quite frankly, clopidogrel has been found to be more favorable in cardiovascular disease, but in the stroke subgroup, it wasn't. There's some indication that perhaps the aspirin dipyridamole combination is more effective than aspirin. There's been a lot of controversy regarding this because there are troubles with trial design and how valid were some of the results and the results reporting from the testing centers. And then there was very recently a discussion of whether or not extended release dipyridamole versus clopidogrel was going to be better. And I thought it was interesting because the authors said we just, as a consensus group, favored the combination therapy versus clopidogrel. And they were very frank about that, and they said we were actually quite surprised to find it doesn't matter. There's really no statistically significant difference between switching between these antiplatelet agents. So if you compare clopidogrel and aspirin versus aspirin alone, so combined therapy versus aspirin alone in the prevention of atherothrombotic events, you find that when you come to the primary endpoint, everything up at the top of the graph, there's nothing statistically significant here as far as stroke prevention or as far as MI prevention. However, at the bottom of the graph, you find that the biggest difference between these groups is the group that has major bleeding. And that was probably the most salient feature that came out of this particular study in 2006. So again, combination therapy for stroke prevention is not recommended. So when you're looking at different antiplatelet agents, I base it on risk factor profiles, perhaps patients with coronary artery disease, so the cardiologist has recommended a different agent versus patients who have stents or who have some other reason to be on a particular antiplatelet agent. Those things need to be considered. Cost needs to be considered. Tolerance needs to be considered. The combination of aspirin with dipyridamole is effective. Combined with clopidogrel increases the bleed risk without decreasing the stroke risk. And again, no data support that raising the dose of aspirin or switching to any alternate antiplatelet therapy in patients for secondary prevention is of any actual proven and significant benefit. So a few other conditions where aspirin is relevant as far as secondary prevention of stroke would include arterial dissections, PFOs, oh dear, PFOs, hypercoagulability, pregnancy, and then what do you do after patients who have had an intracranial hemorrhage? In arterial dissection, it used to be standard rule of thumb, these patients were all anticoagulated for prevention of either primary stroke or secondary stroke. We do know that it's a fairly common cause of stroke in young patients when you go across the board. And those strokes generally are thromboembolic rather than a hemodynamic compromise, so they're, rather than tamponading the vessel. We found, however, that the recurrence rate of stroke is actually fairly low. It's potentially less than even a couple of percent as far as patients, regardless of what you do. And we found that there's not any particular difference in whether you use anticoagulant or antiplatelet therapy. So in 2009 in neurology, this is one representative study, we found that using anticoagulant versus aspirin in patients who had, and these particular patients were carotid artery dissections, that there was really no difference in TIA or recurrent stroke risk. There's a Cochrane meta-analysis that's been performed of many studies over the years that was published a few years prior to this. And there's another coincidence study with this one in 2009 that examined both vertebrobasilar as well as extracranial carotid artery dissection. And the analysis of the data shows that there is really no efficacy for, or really no difference in efficacy between the two. And therefore, the guidelines actually come out with a recommendation that either one of these therapies is effective. And that's a change from what we previously thought. So these patients are actually all very appropriate candidates for the use of aspirin in secondary prevention of stroke. Patent foramen ovale is very common. It's estimated that 15 to 25% of us all in this room have a PFO, and I would grant you that probably not that many of us have had a stroke. It may be more associated with stroke in patients under the age of 55. However, once you reach the age of 55, the relationship between PFO and stroke is far less conclusive. It's also inconclusive as to whether or not patients require an atrial septal aneurysm for this to be significantly related to stroke. We also know that there's just not enough data out there to recommend or establish the superiority either of aspirin or warfarin in treatment of this condition, or even to recommend closure. And a few years ago, the American Heart and Stroke Association issued a call to providers of patients who treat PFO and stroke to enroll these patients in some of the ongoing studies, because those studies are moving along slowly due to the lack of number of patients who are entered. So until we have some really good information, right now we don't have any recommendations. What we do know in one of the in patients who presented with stroke, and there was a combination or a comparison of warfarin and aspirin, there was a sub-study in patients who had a cryptogenic stroke and a PFO. What we did find is that regardless of whether these patients were treated with warfarin or aspirin, there was no change in the stroke risk. And based on this information and some other smaller studies out there who have not shown a particular superiority of one over the other, it's anybody's game. Again, this is in patients who've had cryptogenic stroke who do not have an associated hypercoagulable state. So there is some caveat there. But in patients with stroke and no other determined cause and they happen to have a PFO, secondary prevention is appropriate. It's not wrong to use aspirin versus warfarin versus closure until we have data that actually guide us a little bit more than what we have. Again, we talked about in primary prevention, what do we do with hypercoagulability? And again, there's a significant debate, even in patients who come in with stroke, and we get these hypercoagulable panels, and we find out that they may have some risk factors for stroke. We don't necessarily know, because again, these are venous conditions, not particularly arterial conditions. In younger patients and in pediatric populations, perhaps there is much more of a relationship to stroke. But we don't really even know the mechanism of the risk because, again, it's a venous condition. And even the association with PFO and hypercoagulable state doesn't really hold. We recommend that aspirin is equivalent to warfarin if there is no associated venous thrombosis. Venous thrombosis gets into a whole different world of indications, and we're treating the venous indication when it comes to using warfarin in patients with these hypercoagulable states. We do know that in patients with a venous sinus thrombosis intracranially, the role for aspirin comes as follow-up to anticoagulation, as potentially those patients are anticoagulated 3 to 6 months, and aspirin is the recommended therapy of choice following anticoagulation in CNS venous thromboses. A bit on pregnancy. Low-dose aspirin can actually be considered for pregnant women who've had a stroke, provided that we're talking about the second or the third trimester, and there is no other associated high-risk condition. Generally, we're talking about a documented hypercoagulable state with a venous thrombosis, or high-risk condition being a mechanical valve. And finally, what do we do for secondary stroke prevention after someone who's also had an intracranial hemorrhage? Now, first of all, we recommend to discontinue that antiplatelet therapy for somewhere between those first 1 to 2 weeks. It's pretty reasonable to do. When you're talking about secondary prevention, there are some cases where aspirin resumption is appropriate after intracranial hemorrhage. Now, in a patient who's low risk for atrial fibrillation, and granted this is primary prevention, who doesn't have a history of ischemic stroke, those patients are appropriate for aspirin therapy. If a patient is at high risk for subsequent intracranial hemorrhages because of uncontrolled hypertension or because of a condition called amyloid angiopathy, which increases the intracranial risk, we do recommend low-dose aspirin is the treatment or the preventive therapy of choice for those patients. Patients, regardless of their need, who have poor neurological outcomes, who might potentially otherwise be on anticoagulant therapy, it's also appropriate to treat these patients with aspirin therapy after an intracranial hemorrhage. When do you start it? We tend to start it again sometime after those first 1 to 2 weeks, and potentially out as late as 4. So how do you improve compliance with aspirin therapy? Sometimes I think that it seems so simple to patients. I can buy it over the counter at Walmart. How is it really going to provide me with that? It just seems so commonsensical, but so easy. It's almost too easy, I think. I think is what some people consider. So to improve compliance, first we have conferences like this, and we educate providers by national guidelines, by conferences, by even discussion in the hallways. But we found that is marginally beneficial. We do know that national programs such as the Get With the Guidelines programs or other programs that hold us as providers and as institutions accountable, just by having that knowledge that someone is looking over our shoulder as far as what are we doing with our patients, we found improves our insistence and therefore patients' compliance with using aspirin therapy as far as stroke prevention or other secondary measures of stroke prevention. We've also found that public education is very important, particularly when we target high-risk populations. So these would be the elderly. These would be people who are sociographically and economically disadvantaged. And there are specific ethnic groups that we've found that targeting education for secondary prevention is useful. So the African American community and the Hispanic community. We've found that as we continue to do public education events, either in nursing homes, in churches, in community centers, in some of these ethnic and disadvantaged populations, we are able to improve compliance not only with aspirin therapy, but with the other measures that we put in place as far as secondary prevention. Because I think we know as providers much of the information, but it's getting out to the patients, and that's where all of this really makes any difference. So these are some things and my thoughts about the use of aspirin and what's recommended by the guidelines.